Hi everybody, Jessie here from Team IBS Dietitian. Today my amazing co-host Brooke Keenan and I are going to talk about IBS flare-up relief and also to support those of you who might have had a flare-up over the weekend, because we know traveling, long weekends, holidays usually is when people get more IBS symptoms. So we want to be here to support you, answer your questions. We'll also talk about different types of IBS diarrhea. Yes, there are different types, and depending on what your types are, treatment options will or might be different. Potential triggers. So we're going to talk about three sets of things. One, IBS flare-up relief to help you better manage your flare. Number two, different types of IBS diarrhea. And number three, potential triggers. And we'll do a Q&A at the end. Brooke, I think you need to mute one, not mute, but minimize the sound from one of your devices. Okay. Yeah. Hi, everyone. How has your weekend been? Let us know. Oh, and let me put in, tell us if over the weekend you've had a flare-up. Drop it in the comments. Let's chat about. And Brooke, what did you do this weekend?
I was at the beach, which was lovely and relaxing.
That's awesome. IBS flare-up relief. Let's chat about one. And then two is types of IBS diarrhea. Types of IBS diarrhea. And number three is potential triggers. Potential triggers, so that you can better understand. We'll do Q&A at the end. So for those of you, if you've had a flare-up, let us know in comments. Let's see, I think there's a little bit of a lag here. All right, let's start with finding relief from a flare-up. So usually, what are our recommendations when it comes to faster recovery from a diarrhea flare-up?
Faster recovery.
Yeah.
Potentially fiber, adding in some fiber, going back to a couple days of maybe a safer diet, for safer. Making sure you're hydrated. Sometimes when people get diarrhea, they tend to drink less, but that can dehydrate you and actually make your diarrhea worse.
Yeah, absolutely. Let's go back going onto safer foods, right? I think for a lot of IBS patients, that might be going low FODMAP for a few days to level things out, reduce symptoms, and avoid further irritating the gut. While FODMAPs are usually not main triggers for most people, FODMAPs do irritate the gut, especially if you are somebody with a more sensitive digestive tract. FODMAPs, they draw fluids into the gut, and that can cause more loose stool, and all of the FODMAPs are rapidly fermented in the bowels, and that can again cause more symptoms, usually pain, gas, and bloating. So going low FODMAP for a few days, or if you know what your triggers are, limiting your triggers for a few days, that's going to be really helpful for symptoms. And then also fiber. You mentioned fiber just now. That is a really good one to mention, because fiber works like a double-edged sword, right? For constipation patients, fiber can soften the stool, can help the stool come out easier. And oftentimes fiber also draws fluids into the stool. That's how it softens the stool to help it come out easier. So that helps. But for diarrhea cases, it actually helps bulk up stool. And when there's more bulking agent for the stool, people's bowel consistency or the stool consistency tends to improve slightly. If you are in a flare, or for some people, it improves drastically. Okay, what else? I would say maybe trialing even peppermint oil capsules can
Mm.
sometimes be helpful. We usually recommend IV Guard. IV Guard is the one that has evidence to it. There's another brand too called Heather's Tummy Soothers, and that is
Tamers.
a tamers, yeah, and that is a different type of peppermint oil capsule that potentially can help release gut spasms. So the way peppermint works is by reducing the spasms of your gut. What else? And I love what you said about hydration too, because oftentimes when people are running to the bathroom multiple times a day, they are losing more fluids. And not everybody is aware that, hey, when you are losing more fluids, you really need to be improving your fluids. And for some cases, if your diarrhea is more significant than just a few diarrhea a day, you might even need to replenish some electrolytes. Now, you don't have to go out of your way to spend a ton of money on electrolytes, but something as simple as adding some salt into your water can help you get more electrolytes. Or if you can tolerate Pedialytes, that could be a really good one to add to your fluids when you have a significant flare up. Okay, what else helps with flare-ups? Now, when we talk about flare-up, I think one of the things we want to talk about is bloating as well, because oftentimes, depending on a person's IBS subtype, a flare-up can mean very different things. Um, and bloating is often something we hear. What are some more common causes to bloating that we know of, that we see a lot of in our clinic?
Well, definitely could be FODMAPs. So FODMAPs can definitely cause gas and bloating. Constipation, which is not what we're talking about today, but constipation can sometimes cause bloating. And something that we touch on in our clinic, it's not usually the main driver of bloating for our people, but actually swallowing air using a straw, things like that sometimes can contribute to bloating.
Mm-hmm.
Um,
We don't talk about that one for sure. Is when you drink from a straw, you swallow more air, and the air goes
mhm,
into your digestive tract. That can cause more bloating. And chewing gum is another one that can cause us
mhm,
to swallow more air. So if that's your habit, just keep an eye out on it when you are drinking from a straw or doing chewing
mhm.
gums. And sometimes, you subconsciously you're just swallowing more air, and that can cause symptoms for those people who are struggling with bloating. You were going to say something else. Yeah.
I actually was thinking, um, which actually led to me to another thought. We may not address it all the time, but when we have people do diaphragmatic breathing, which is something we do all the time,
Yes.
that can help with bloating, even if you're swallowing air.
Yes. Deep diaphragmatic breathing, it helps with bloating, it helps with diarrhea, it helps with pain management when it comes to IBS because it really
Mm-hmm.
helps you reconnect your gut-brain axis, or just improve the connection of your gut-brain axis. And that tends to help with bloating a lot. Actually, one of our clients, she said when she was working with us, she was also working with a physical therapist to work on improving her pelvic floor muscle health. And one of the things we do with her is, of course, diaphragmatic breathing. And it was the same with the physical therapist. And it's so interesting. The physical therapist have her measure her belly when she's bloated. And she said she was bloated, so she measured. And then she did deep diaphragmatic breathing for just a minute or 2 minutes. It wasn't even that many times, right? So a few breaths. And it shrank her abdominal area by 2 inches. So
Wow.
remember, this is a really good tool. Yes, everyone is
Mm-hmm.
different. Not everybody's going to see that kind of shrinkage, and you have to do it consistently. It really helps strengthen your abdominal muscles and your diaphragm muscles so that it helps better support your organs. And of course, improving pelvic floor health is always important when managing GI issues because the pelvic floor is what holds everything at the bottom together. So we're always talking about deep diaphragmatic breathing, but beyond the muscles, right? It also reconnects your gut-brain axis. It helps you not feel, not go into fight and flight mode. That's something Dr. Navidi and I talked a lot about. Well, he talked a lot about in our podcast episode on the gut-brain axis and gut-directed therapies for IBS. He's the founder of GI Psych and a very established GI psychologist. So go listen to the IBS Nutrition podcast with the episode and the episode with Dr. Navidi on it, if you want to learn more about GI Psych and some of the things he talked about that you can do to prevent, to manage symptoms. Can register for the live, please. Sorry, what do you mean by that? You want to register? It's the podcast. We're doing the live here. We're talking about IBS flare-up supports today. So relief. What did we touch on just now? So we talked about hydration, electrolytes if it's a really bad flare-up, and we talked about deep diaphragmatic breathing and maybe avoiding using straws or chewing gums. Well, actually, especially chewing gums, because most chewing gums also have sorbitol or mannitol or xylitol in them, and those are high FODMAPs, and these are also agents that draws fluids into the GI tract and can cause more diarrhea. So beware. A fun fact about chewing gum is that, after surgery, when we work in hospitals, right, after patients have surgery, one of the things we monitor is whether the patients can have a bowel movements, and we know if their GI tract has, or whether they can pass gas or not, to know that if their GI tract has woken up from the surgery after anesthesia. So usually what we tell patients to do is, if they are not passing gas yet, we will give them chewing gum to chew to help them wake up their GI tract. And then, of course, when you chew chewing gum, right, and if there's a lot of sugar alcohol in them, it can also lead to more gut motility for those people with more diarrhea. You might want to avoid that. Okay, so what else did we talk about just now? Oh, peppermint oil capsule. There are two brands out there that can be helpful. One is IB Guard, where the research was really done with this brand. The other one is Heather's Tummy Tamers. That one, the research was not done on it, but from the product and from hearing from our clients, it might be helpful as well to ease the intestinal cramping. Oh, last but not least, going low FODMAP for a few days. If you're in an active flare, that way you're reducing gut irritant in your gut, because that can potentially cause you to have more symptoms. And whether that is bloating or diarrhea or pain, going low FODMAP for a few days can be helpful, but be mindful that the low FODMAP diet is not a long-term diet. And we are going to talk more about this when we talk about potential triggers, so later on. Well, next, let's go on to, different types of diarrhea, right? So when we talk about treating diarrhea, one of the most important things we see is that IBS diarrhea is being treated the same across the board, no matter what type it is. I think really the key is to identify what type of diarrhea you have, so we create the right treatment plan for people. Before we go into different types of diarrhea, let me actually do a quick shout out to say that our full IBS Freedom Program is actually open for enrollment. We have 6 spots opened. Actually, we only have 4 spots left right now. Enrollment closes on September 30th or whenever we fill those 4 spots. And this is going to be the last group, the last small group in 2025. And you can watch our free IBS Masterclass to learn more about our approach and also what the program looks like. And by just watching the masterclass, you get to save $500 before you enroll the program. Okay, and this is the last group in 2025. Prices increasing in 2026, just FYI, for those of you who are ready to manage your IBS for good. Okay, well, now let's talk about different types of diarrhea. But before we talk about different types of diarrhea, let's talk about some of the struggles that we hear from our patients when it comes to diarrhea, because it is debilitating, to say the least, and it's embarrassing, right? And sometimes it's just painful. Painful is something that you experience, but I think embarrassing, the shame that comes with it, is something that we don't talk about enough. And for those of you who are watching, if you ever feel that way, we just want to let you know that you are not alone. And
Mm-hmm.
we have worked with so many people who have had very urgent diarrhea. Sometimes they even wear diapers when they go to work or when they go to bed because they don't know when the diarrhea is going to hit. So if that is you, remember you are not alone, and there are a better way to manage it. But first, let's talk about different types of diarrhea, because different types and then different triggers, right? Different types themselves have different triggers. So let's go on to the first type we want to talk about. Brooke, you want to lead us onto that conversation, which is malabsorption diarrhea.
Yeah, so malabsorption diarrhea can be, well, just like it sounds, your things are moving so quickly through your system, you're not absorbing your, nutrients the way you need to be, and that can be from fat malabsorption. Possibly taking medications can contribute to that, and what we sometimes see is supplement usage. A lot of supplements, or just really any one supplement, if you're taking it in the wrong dosage or it's contaminated or whatever it is, can definitely lead to malabsorption, which would be diarrhea because things are moving so quickly.
Right. And even within malabsorption diarrhea, right, we often see fat
Mm-hmm.
malabsorption being one of the number one factor in one type of diarrhea. And there are two types of fat malabsorption that can coexist with IBS diarrhea. And one of them is bile acid malabsorption. And that is when people would have burning diarrhea, and it is just one of those very unpleasant diarrhea, and you will sometimes see fat floating on top. And I think oftentimes patients realize that quickly and they stop eating fat, but the diarrhea may still continue. And then another type of diarrhea is exocrine pancreatic insufficiency. Again, this is your pancreas is not making enough enzymes to break down the fat, causing too much fat to be in your stool. And that can irritate the colon as well, causing people to have diarrhea with fat in it. And both of these conditions, yes, you can technically test for them, but testing for them is extremely tricky. Oftentimes, you can work with your provider to get to trial medication. Now, here's the tricky part, because sometimes IBS diarrhea may look like bile acid diarrhea, but
Mm-hmm.
then it goes back and forth between solid stool and mushy stool. Something we have seen quite a lot in our clinic lately is that patients who fluctuates a little bit more on solid stool and diarrhea, and when they start taking the medication for bile acid malabsorption, it goes to completely watery diarrhea. And even Imodium doesn't work in some of those cases. So be aware, if you're trialing any medication with your physician, always talk to the physician about what is this medication going to do? How soon will I see changes? What changes am I going to see, so that you have some measurable outcomes? And know that when it's not working, you know when to stop. So in both of these cases, I think one of our clients, he actually stayed on the medication for almost a month, and we kept telling him, we think the medication is making your diarrhea worse. So he went from overflow diarrhea to maybe somewhat of a normal consistency when we told him to cut out certain foods that we thought it was his food triggers. And then his physician recommended trialing a medication for bile acid diarrhea, and that ended up actually making him go all out on extreme diarrhea, that even Imodium wasn't working as well. And once he stopped the medication, he actually slowly got back to his baseline. And unfortunately, we are seeing that more and more often in our clinic. And in these cases, we actually coordinate with the patient's doctor to talk about, hey, we think we could trial this medication, but let's take it one step at a time. Let's dose it up slowly, or let's dose it back down slowly. And sometimes, of course, some of our clients also take other medications that can cause more gut symptoms as well. And that's something we are watching for. One of our current clients actually, we stopped her diarrhea. So one of our clients right now came to us for a lot of diarrhea, again on Imodium. And recently she started 2 new medications, and the medications actually again made her diarrhea a lot worse, where she has to actually get up in the middle of the night to run to the bathroom and having accidents and really making it difficult for her to live her normal life, do her job, and also taking care of her family, which, for those of you struggling with diarrhea, we know it is debilitating. We can't say we've been there, but we have worked with so many individuals that have dealt with this. We know how debilitating it is, and it's always our best interest to really look through everything to see what the culprit might be. And in this case, this new case that we are working with, one, we do think she has a food trigger, which when she removed the food trigger, she felt so much better. But the problem was she added on the medication a little bit sooner than we could get to her actual baseline. And as soon as she added on the medication, her diarrhea got worse. And when she added on that second medication was when Imodium wasn't even working for her. So we looked through what she's eating, the medications she's taking, when she started them, and what her bowel movement looks like for the past month to say, hey, this is the pattern we are noticing. Here is our recommendation. Let's maybe dial back on the medication. Let's get you back onto your baseline first before we add back on the medication. And we are working with the patients closely, and we're working with their physician as well, because every time she goes to her physician, one of the things we do is we tell her what to say to her physician by, looking at everything that is happening. Because sometimes, well, I shouldn't say sometimes, you only have 15 minutes with your specialist. You need to get your message across. How do we say this? Coherently, and make sure your physician understands where we are coming from. And I think sometimes, especially with IBS diarrhea, is physicians might recommend, say, okay, go try Imodium, tell me how things are in 3 months. And then in 3 months, you're like, yeah, I'm taking Imodium. I'm not going to the bathroom as much as I did, but I still don't know what's causing my diarrhea. Like, sometimes it can be frustrating, but if you are going in and say, hey, look at my stool, this is what it looks like, should we try something else? We actually told the patients, like, let's show your physician the pictures. We think this might also be contributing to your diarrhea. These are the medications we recommend trialing. But then, of course, after we trialed it, we see that the medication is making it worse, and we're backing down from it. And we're so happy to report, about these new patients we have. So her diarrhea has gotten so much better. Actually, she stopped having diarrhea. It went from, I think, like 10 to 12 times a day, now back down to no diarrhea for a few days, and maybe 1 to 2 bouts of diarrhea every few days. So much better than before. And she's actually preparing for a long haul trip this coming weekend. And the next session, when we see her this week in small group program, we're going to help her create a travel plan. We've already talked a lot about that. And I think one of the things with diarrhea is travel can be so hard, whether it is road trip, whether it is flying, and sometimes even driving 5 to 10 minutes, right? If you don't know when the diarrhea is going to hit, it makes it so difficult. So this week, we are just so glad to see that her diarrhea has basically stopped, and hopefully we'll get her back to baseline soon. And the next step of working together is challenging the food that we told her to eliminate. So this patient, because of her diarrhea is so significant, we have recommended a couple elimination diets. And then the next step is to re-challenge each group of the foods step by step to see what she tolerates, what she doesn't tolerate, and more importantly, the level of tolerance. Now, I'm pretty confident she'll be tolerating most of the FODMAPs. Again, now that we've really gotten her closer and back to her baseline. But sometimes with diarrhea cases, it is just challenging. It's hard. Anything else to add?
No, I think you covered it.
Well, for those of you listening, I know we have quite a few viewers on Instagram. For those of you listening, if you have any questions, drop them in here. Well, we've only really just talked about one type of IBS diarrhea. Let's move on to the other types, right? So do you want to talk about overflow diarrhea?
Yeah, so overflow diarrhea is when you're actually really constipated. So there's hard stool kind of blocking your colon at some point, and then it gets so that your you still are producing stool, but that would be liquid stool. So then the liquid stool kind of leaks around the harder stool. So it appears you're having diarrhea, but it's that the root cause of it is actually pretty bad constipation. So you need to get rid of that blockage of constipation and have more regular bowel movements. And a lot of times that will resolve your diarrhea.
Yeah, overflow diarrhea is actually something we see a lot of. I got my prompts to explain it better, but let's talk about some of the symptoms of overflow diarrhea. So in cases like this, people usually go to the bathroom many times throughout the day. We'll say many times is anytime you eat something or you're moving a bit more, you're exercising, you will want to go to the bathroom. So anytime there's stimulation going through your GI tract, you want to go to the bathroom. But the only thing when you go to the bathroom that comes out are watery, liquidy stool. And that is because there is a bulk somewhere in your tract, usually closer to the descending colon and the rectum, like usually something stuck here. And it can't pass. And when that happens, your GI tract, your colon will still try to contract and try to squeeze out the stool. But when it can't do that, what it ends up doing is squeezing out the new stool, and the new stool will be bypassing the old stool and come out in the liquid form because the solids cannot pass. And oftentimes with overflow diarrhea, there's a lot of pain, there's a lot of urgency. It happens many, many times a day, and people get really afraid of leaving their house or even doing anything at all. So in cases like this, like what Brooke was saying, the root cause is constipation, and the key is to understand what is causing the constipation. And very interestingly, I think in a lot of cases of overflow diarrhea that we see in our clinic, oftentimes people have a food trigger. And what happens is when they have the food trigger, it causes very slow gut motility. Very slow gut motility, and then the stool tends to build up. And when that buildup happens, people will start having bloating, people will start having pain, a lot of gas, trapped gas, and then overflow diarrhea may happen after that. Not everybody gets overflow diarrhea, some people do. And then when it happens, they get diarrhea and they get diagnosed as IBS diarrhea. And oftentimes these patients will really struggle with their symptoms. And one of our clients, I think her name is Mercedes, right? She had overflow diarrhea and she went to 4 different GI doctors. The third GI doctor said, you probably have IBS. And then it wasn't until she came to us after seeing 4 GI doctors and many years later, we were like, we think you might have overflow diarrhea. You can listen to Mercedes' story on the IBS Nutrition Podcast. I can't remember what episode it is. We'll tell you that in a little bit. But what happened was when we identified the overflow diarrhea, here's the first thing we do. We helped her unclog first, and it's perfectly fine using some over-the-counter laxative because you really need to get rid of this block. And then your colon will still be very stretched out if you have had stool burden for a long time. Resolving the actual constipation and improving gut motility is a process, and it can take a long time, but the key is consistent food evacuation every single day. Now, and in Mercedes' case, she actually did have food triggers, and when she eats these food triggers, her gut just slows down significantly. And once we identified the food trigger, well, by again doing systematic elimination and challenge reintroduction, we know what food caused her gut to slow down so that she can, 1, avoid her triggers moving forward, and number 2, if she eats some of her triggers for the triggers that she can actually tolerate, what steps she can do to help improve the gut motility again so that the stool does not get stuck here, leading to stool burden and overflow diarrhea. So it's really key, right? Even with overflow diarrhea, step 1 is removing the stool burden. Step 2 is identify what is causing the slower gut motility. And step number 3 is having a plan in place to prevent the stool burden from coming back. Retraining your colon to have full evacuations every day can take a long time. It is consistent full evacuation every single day that is key to really getting the elasticity back to your colon. And it's a step-by-step process. So, but don't give up. There is hope. So for those of you listening with diarrhea, this is another, again, one more potential type of diarrhea. But let's move on from our list. I think the next one we have here is IBS mixed bowel type. Sometimes we also call this flare-up diarrhea in our clinic. Do you want to talk a little bit more about this?
Sure. So flare-up diarrhea would really be eating a food trigger, and it causes diarrhea. Or
Yeah.
constipation, but usually diarrhea.
Right. Or sometimes people get constipated over a few days. And
Mm-hmm.
then when they eat their food trigger, not knowing that it is a
Yes.
food trigger, it causes them to have diarrhea. And sometimes
Mm-hmm.
they might be stuck on the bathroom for hours. And sometimes we
Mm-hmm.
even hear patients say, oh my goodness, the diarrhea started and I had overnight, I had so many bowel movements overnight. And I finally felt better. And sometimes that cycle just starts again.
Mm-hmm.
Now, some people, it can be caused by significant backup of the colon, right? Significant stool burden. Again, in those cases, really work on gut motility, improving motility, your fiber, hydration, movement, sleep, stress. It's so many things that affects gut motility. And for women, it's your hormones as well. Because as every month, our hormone just changes. That can change your gut motility as well. So it's really important to keep a symptom journal and your bowel movement journal and your food journal to kind of track to see what may be going on. If you don't do it now, but if you're on Instagram, you can go to any of my posts and type in symptom, and I'll send you a link to download our free symptom tracker. It is extremely helpful because at the end of the day, when it comes to managing IBS, which is a chronic condition, you need to understand your body. You need to know what's going on in your body leading to having symptoms. When you see that full picture, it is way easier to manage your IBS. Don't wait until you're in your 60s and 70s and 80s to come to manage your IBS. I have to say we actually have a lot of I wouldn't want to say older ladies, but more mature ladies in our programs. While I just retired, I just
Mm-hmm.
retired. I finally have time to manage
Mm-hmm.
my IBS, and now I want to get it managed so I don't have to suffer anymore. I think Laura is probably both Laura and Mercedes. Laura is close to, no, Laura just retired. Mercedes has retired. And don't wait until you are near retiring age, because when you have a chronic condition to manage, and if it's not well managed, it's really making it difficult for you to live your life to the fullest. Even if you're taking care of your family members or just taking care of yourself, or if it's achieving better in your career. And I know it firsthand because when you have significant IBS symptoms, right? The pain, the gas, the embarrassment if you have diarrhea, or the shame, and this is a lot of mental burden that you have to carry around with you. It makes it so much more difficult to do your job properly. Sorry, I got distracted again. Let's get back to different types of diarrhea. Oh, it's getting warm in here. We have a heat wave in the Pacific Northwest this weekend. Whew. And we don't have AC. So heat actually is a trigger for IBS as well. So if you are experiencing more flare-ups this summer, make sure you stay very well hydrated. We talked about this earlier, talking about flare-up relief. If you need some electrolytes, that's perfectly okay if you have a lot of diarrhea. But don't choose something that have artificial sweeteners in it, because it can potentially make your diarrhea worse. Choose something that I think Pedialyte may be the better option. I would say avoid. You can try out Body Armor. I think that is coconut water based, but coconut water is not low FODMAP. So just something to watch out for. There are many options out there. You can also make your own solution at home by adding some salts to your water, because the main electrolytes we want to replenish here is sodium. Okay, the next type of diarrhea. I think this is one that we work with patients on the most, and that is the food intolerance diarrhea. So this is food triggering gut symptoms. And what are some food groups that can trigger gut symptoms?
FODMAPs,
One.
lactose. So FODMAPs are fermentable carbohydrates.
Mm-hmm.
Lactose, which is part of FODMAP, but can be
Okay.
a trigger on its own.
Right?
Fructose intolerance,
Okay.
uh,
Which is also
non
part of the FODMAP group, right? So we have,
non-celiac, yes, correct,
yeah,
non-celiac wheat sensitivity,
okay, 4,
uh, histamine intolerance,
5.
or sucrose isomaltase deficiency.
Right. So we're talking about 6 groups of food intolerance here. When it comes to managing IBS, we do have to say the low FODMAP diet is the #1 recommended diet for managing IBS. However, it's not a long-term diet. It's a short-term elimination diet, and you need to do a group by group reintroduction. Like we said earlier, right? So we talked about FODMAP intolerance, lactose intolerance, fructose intolerance, non-celiac wheat sensitivity. This is a group of people who don't tolerate wheat, which includes gluten, ATI, and maybe potentially something else. And but they don't have celiac disease. And then histamine intolerance, we usually see this in some IBS patients, and sometimes usually they also have mast cell activation syndrome, and then also sucrose isomaltase deficiency. This tends to be more common in children. They're diagnosed more in children, but there are diagnoses of people having this in adults as well, and you can get these diagnosed. But ultimately, the key is to identify which group of food intolerance you have and how much of the food, if you are intolerant to them, can you tolerate. Now, even though the low FODMAP diet is the #1, is the gold standard to managing IBS, we always say that it's not a long-term diet, because it really is not. And the key, one thing is really key, is to understanding what's causing your diarrhea or what's causing your IBS symptoms and resolving the root cause. Food can be part of it, but when it comes to FODMAP, yes, it triggers symptoms, but usually what we see is when people resolve the root cause of what's causing their symptoms, right? If it's malabsorption diarrhea or if it's overflow diarrhea, when you resolve the root cause. So it could be, resolving whatever is irritating or causing the fat malabsorption. Or overflow diarrhea's case would be the chronic constipation. After you resolve the root cause, people's FODMAP tolerance will improve drastically. And over time, what we see in our clinic is people can eat most of the FODMAP groups again, if not all of them. But I will have to say, I think a lot of our clients can eat all of the FODMAPs again. Maybe besides 1 or 2 groups that they can tolerate a smaller amount. So they can't eat the full serving. For example, apples, right? Apples have 2 groups of FODMAP, sorbitol and fructose. Like in those cases, you eat the amounts that you can tolerate, and you continue to eat that to improve your tolerance. Whereas I think a lot of the times when people are told to trial the low FODMAP diets, they go all in and cut out everything. Sometimes they're cutting out the right things, sometimes they're cutting out the wrong things, which is also, again, something we see very commonly, especially there is a lot of misinformation when it comes to the low FODMAP diet. And then there are also 2 different versions of the low FODMAP diet. Monash came out with a new batch of updates last year and this year, and some of them I think is better because it expands on what is the low FODMAP allowed limit, but some of it becomes more restrictive, and we always hate this. For example, tomatoes. Tomatoes in the old recommendation works for most people. We are not going to tell you to restrict more tomatoes if it works for you. But if it doesn't work for you, then maybe follow the new guidelines. I think it's half a Roma tomato is low FODMAP. In the past, I think it was 1 or maybe 2 Roma tomato that is allowed in the low FODMAP phase, which most people tolerate it anyways. So if you tolerate the food, don't cut out even more. The key is to do a systematic reintroduction to see what you can and cannot tolerate. Okay, now let's talk about, I want to actually give an example about non-celiac wheat sensitivity, because that is something we see quite often in our clinic. However, there's a lot of stigma with it. One of our previous case, this is actually a nurse practitioner herself, and she works in family medicine, and she came to us for SIBO and nonstop diarrhea, and her doctor told her to do the low FODMAP diet, and she was on the low FODMAP diet for a few months already before coming to us. And she said she's really afraid of eating FODMAPs because every time she eats FODMAPs, she runs to the bathroom. Now, when we worked together, we also look at medical history, what other diagnoses she has. And after reviewing her history and her family history, I noticed that she is at higher risk of potentially having non-celiac wheat sensitivity. And I told her, here's what I think we need to do for your case. We want to cut out gluten for a short period of time to see if that improves your symptoms or not, and then challenge it again to see if it causes you any symptoms. And lo and behold, when she removed gluten, her symptoms got better and better. Within 2 to 4 weeks, she was basically back to baseline. And then we did a challenge, and her diarrhea came all back. Now, she came to us for guidance for the low FODMAP diet, but instead, we really focused on what we think was her real trigger. She was already doing low FODMAP, so we didn't have her go full-blown FODMAPs yet at that time because her gut is very sensitive, it's still recovering. But once she got back to her baseline after identifying her triggers, we were able to reintroduce every single group of FODMAPs back into her life. Every single group. She has cut out apples, what else? Peaches, avocados, garlic and onions were big ones for her because she knows everywhere she goes, she will get some garlic and onions. And it makes her so afraid. I remember at our, I think, second to last appointment, right? She said, she went to this restaurant and it had onion in it, but she knew she was able to tolerate it. So she did not go into the fight and flight mode. Sometimes, when you don't know, you go into fight and flight mode, and the fight and flight mode might be the one thing that is causing your symptoms. But because she knows that I can tolerate onions, I will be fine eating this meal. She did not get an anxiety attack and cause herself to have diarrhea. She was fine. And sometimes in cases like this, right, it takes time for them to be like, well, I know I can tolerate this. But, every time you eat your trigger food or what you think might be your trigger food, but really is not your trigger food, it gives you a bit more confidence to know that I can eat this. It's not going to send me to the bathroom. And in fact, some of our current patients, we are working on this as well, is to give them the confidence again to do the challenge first so that they know they can tolerate it or how much they can tolerate. And then when they eat this food, we reinforce the idea that, hey, we've done the challenge. We know you're fine. You can actually eat this. Go ahead and eat this. Go ahead and enjoy that barbecue with your family that has maybe garlic powder or onion powder in the marinade. Yeah, so my point is, low FODMAP can be a trigger, but oftentimes it's not the ultimate trigger. Yes, the low FODMAP diet is gold standard when it comes to managing IBS, but it's not a long-term diet. You really need to be working with an experienced provider. So normally what we do is when people are going low FODMAP, we use that time to investigate the root cause, and then either identify the trigger or improve gut motility or whatever else is going on, right? Or maybe working with another medical condition, for example, with SIBO, right? That's what we see a lot of as well in our clinics, like work on the root cause and then improve gut function, improve food tolerance, and then we do the FODMAP challenge to help our patients know that, hey, I can actually eat these foods without worrying so much about it. And that is, I would say, what we call IBS freedom, right? You're really understanding what's going on in your body, reintroducing foods that you've cut out in the past, well, understanding what's going on in your body, resolving the root cause that is causing your symptoms, reintroducing food that you've cut out in the past, and really expanding on your diet. Ultimately, your gut thrives on a varied diet, a diet with at least 30 different types of plant-based food every week to have optimal gut microbiome. When you are cutting out so much food, especially when it comes to the low FODMAP diet, you're really cutting out a whole host of things that are good for your gut and good for your gut microbiome. It can lead to longer symptoms over time because you are reducing gut microbiome variety, you're increasing sensitivity to those foods because you're not eating them for so long. And then again, another thing is leading to more food fear and not able to live a normal life. So for those of you who might be, on the low FODMAP diet, know that it is temporary. Don't stay on it for a long time. Okay. And do you have anything to expand on the low FODMAP diet or any other kind of food intolerance that we talked about? We talked about so
Uh,
many types.
no, I think you covered it. Yeah.
Yeah. But again, for those of you who suspect a food intolerance, do not try to diagnose it yourself. It is extremely hard and it is very, very confusing because we just talked about multiple different types of food intolerances, right? FODMAP, lactose, fructose, non-celiac wheat sensitivity, histamine, sucrose, isomaltase deficiency. Oops, sorry, I think I got cut off because something popped up. But there are so many different types of food intolerances out there that can be causing your IBS symptoms. Don't guess it by yourself. We see people guess wrong as we see people cut out so many food all the time. Going gluten-free, dairy-free, low FODMAP, going keto, going carnivore, going paleo is one that we see quite often too. It's not necessary, and it's really difficult to live a normal life. Yes, is there a place to rewatch the beginning of this video? Yes, absolutely. In the beginning, so here's what we talked about today. In the beginning, we talked about IBS flare-up relief, so giving you different tips to find relief from IBS flare-up. So hopefully we can shorten the days or the times that you have symptoms. And then the second thing we talked about is different types of IBS diarrhea, because it's really important for those of you struggling with diarrhea, identify your type of diarrhea. So we talked about, how many types did we talk about? 1, 2, 3, 4. 4 different types of IBS diarrhea that we see often. And also talk about the characteristics of different types of diarrhea so you can better match your type of diarrhea to what is causing symptoms. And then number 3, of course, what we're talking about now is potential food triggers. So there are many different food triggers out there. Don't try it yourself. What we often see is people cutting out all the foods and they still experience symptoms and they become extremely afraid of food. And sometimes some cases are so severe that we think that they have an eating disorder. And there is one type of eating disorder that is pretty prominent in GI disorders, and it's called RFID, avoidance food restricted intake. Did I get that right? I think so, yeah.
Avoidant restrictive
Yeah.
food intake. Yeah.
Yeah. So that's one type of eating disorder that's related to, that is pretty common in GI patients. However, that is quite extreme, but more often we see people with disordered eating behavior, like not eating when they are doing important things, right? Prolonged not eating because they're afraid of symptoms, or only eating 5 foods that they feel safe eating, or so much more that people are doing. Are there tests needed to find out if you have histamine intolerance or wheat intolerance? So there's no test for wheat intolerance right now. The only way to test wheat intolerance or non-celiac wheat sensitivity, the medical term for it, is by doing a proper elimination with a reintroduction, with a challenge, and monitor symptoms. And oftentimes we see with all of the different food intolerances, one of the things we say don't do your own elimination and reintroduction is it can be very confusing. Depending on what food you are reintroducing, symptoms can start right away, or symptoms can start a week or 2 weeks later after you reintroduce the food, depending on what we are challenging. And sometimes symptoms can last maybe for a few days or up to a month. So, you have to know, the food you're challenging, what symptoms it usually cause, when symptoms usually occur, and how long you need to be at, baseline with the food when it comes to challenging that food. So it is extremely confusing, and I would say most dietitians are not trained on this. Specific GI dietitians are trained on this and helping people with the elimination and reintroduction process. And one of the things we do is to really looking at our patients' poop. As gross as it sounds, we love it. But we actually have a podcast episode talking about why looking at your poop is so important when trying to manage your IBS. And of course, all of our clients come onto our podcast sharing their story. That's something they talk about as well. It's not gross for us. We love seeing poop. And when we see poop, we know whether the strategies we're implementing is correct. Like, we want to see the trends of your stool. So is it getting better and better? Is the consistency getting better? Is the quantity getting better? Because oftentimes, right, it's not just your stool type. We're looking at quantity as well, and also the consistency. Is it the type 4 stew? How many cups is it? How many bowel movements did you have that day? What does it look like compared to your norm or your baseline? Oftentimes, when we do a food challenge, the first things that tells us you reacted to a food is your stool consistency have changed. And sometimes that happens before symptoms even show up. And what I talk about when I talk about symptoms is it can be bloating, it can be pain, it can be, and some people even get reflux. So it depends on, what food it is, what your individual triggers are, and everyone have different symptoms. So it's very important to do it properly and document all of the symptoms appropriately so we can watch the trend when people are testing food. And when we are testing for food intolerance, it's not hey, you eat it for one day and be done. It's usually over 3 to 4 days so that we can watch. At a very small quantity, can you tolerate this? At a bigger quantity, can you tolerate it? And then at a full serving, what happens? Do you have any symptoms? So that is how you know once you are done challenging all the food groups, what your tolerance, whether you tolerated the food or not, and what your tolerance level are to the food, because that is so important, right? So that you can eat that food again in the quantity that you can tolerate and not cut out food thinking that you can't eat it when in reality it's fine. Okay, so yes, to answer your questions, no, there's no test. Is there a test for histamine intolerance? There is a.
I'm not sure.
I'm not sure, but I think it's more of a symptom assessment when it comes to histamine intolerance. And again, with histamine intolerance too, we pile on the low histamine diet with the low FODMAP diet. And then if there are other potential triggers, then we add it on. It is extremely difficult to maneuver. Do not try it yourself, okay? I can't express this enough, because when we pile on elimination diets, the key is to identify your triggers and the level of tolerance. But when people don't know how to do it by themselves, you might not be doing it correctly, and you might be adding more unnecessary restriction to yourself. And I would say, even working with a dietitian, right, you want to make sure you find somebody who understands all of these diets inside and out. So that one of the things I would have to say when working with a dietitian, here's what you need to look for. Look for the dietitian helping you implement the diet properly, and not just say you need to cut this out, you need to cut that out, but instead helping you find alternatives that actually works with your budget, with your time, and what is accessible for you. I love how a lot of people are talking about kiwis, right? Kiwis resolving constipation. Eat 2 kiwis a day. But kiwis is like $10 a box in Seattle. I'm not going to recommend it out of, everybody's way to say, hey, go buy kiwis. Let's find something that is accessible for you, that is within your budget, and that actually works, because there are so many things we can do to improve, your symptoms. It's not just one size fits all, but a good seasoned dietitian will help you within your realm of, what is possible for you to find solutions. And I think that is really key when picking a dietitian. Look for somebody to help you be successful. Mm-hmm. Avoid practitioners. We actually hear this more often about naturopaths putting people on elimination diets. And when people fail the diet, they blame the patients. It breaks my heart. Every time I hear that, it just makes me so angry when providers tell people to go on extreme elimination diets without actual guidance. And then when patients say that, well, I cheated on it, or I don't know if I implemented it correctly, they blame the patients for failing. No, you have not failed. If somebody recommended you to do something and you couldn't comply, the key is really getting the right support so you are successful. And sometimes I'm mad at the GIs as well, because they're recommending people to do the low FODMAP diet, but don't give people any guidance on how to do it. They say, just go Google it.
Or a one-page handout.
Yeah. No, that's not going to help you be successful. No. The key of helping you being successful is actually looking at things that you can actually eat, and working through, what your day's meal would look like if you're on a low FODMAP diet, or if you're on, say, a gluten-free diet, or if you're on a histamine diet, low histamine diet. So just remember that. Actually, we talk so much about this in our free IBS masterclass. And I want to say thank you for everybody that joins today. Do we have any other questions? And before we go, I just want to do a quick last minute shout out for those of you who are ready, to really understand your IBS and to get your IBS symptoms under control. We have opened enrollment to our last small group program of 2025, and that is working with both of us directly in a small group setting. You get 14 sessions with us because, like I said earlier in the session, symptoms changes pretty quickly, and whenever symptoms change, we need to know whether it is a good change or a bad change and change our strategies accordingly. IBS is complex. It's very complex. It requires a lot of support and guidance from an experienced provider, which is why in our program is 14 sessions. You get support from us for 4 months. And also why we hear from our clients a lot that I've struggled, like Laura, who came onto our podcast to talk about this. She worked with her GI for 5 years. She was struggling with debilitating diarrhea, and she worked with her GI for 5 years with no solution. We worked together with her for 4 months. She got the correct diagnosis. She had SIBO. We identified her food triggers, and she moved on with her life. We worked together last year, and at the end of working together, she went to Croatia and she traveled for 3 weeks, going hiking, biking, just doing all touristy things without worrying about symptoms. And she actually was very nervous when she was finishing up her program. And Brooke said something to her that Laura said in the podcast is, well, we are still here if you need us. Your program is ending. And she said, the last year, she hasn't had any incidents where she doesn't know how to handle it or doesn't know how to bring her symptoms back down to baseline. Mm-hmm. And she is becoming more and more confident in managing her IBS and living her normal life. And we are so grateful for her to come on to our podcast and share her story. Because when you are in the deepest of having a flare-up, sometimes it just feels like this is going to be my life forever. We want to let you know that it is not going to be your life forever, but it does require a systematic treatment process. I would say one is identifying the right treatment for you. Number two is having a process and getting the right guidance and support through the process so that you are successful. Which is also why we love our program so much. Even though it is 4 months, it might seem long, but in the grand scheme of things, if you've struggled for a lot of years, this might only be the 4 months that you need to invest in yourself and get it all down to the baseline, really understand what's causing your symptoms and having the tools to prevent symptoms from happening in the future, and also having the tools to bring your symptom down to baseline as fast as you can in the future if symptoms do occur. Because IBS is a chronic condition, there's no magic fixes. If there are magic fixes that somebody is trying to sell you, run. There's no quick fixes. But anyways, enrollment is currently open. We have 6 spots open. We only have 4 spots left. So if you're interested in working with us, comment group in this video or any of my posts. You can look at some of our other posts that talk about it. We actually had the pinned post. Well, no, it's not pinned. We had a post that talks about our program. Go swipe through and learn more, and watch our free masterclass where we talk a lot about our approach, walk you through step by step what we do, and also what the program includes so you have a better understanding. And just by watching the masterclass, you will get $500 off when you enroll to the program. And reminder, this is the last group of 2025. And because of inflation, unfortunately, our price will increase in 2026. So if you're on the fence, I would say don't wait. And for this last group, you can start anytime in September or early October. There are flexibilities. You always start with your first one-on-one appointments and then followed by 12 weeks of small group program. In the first one-on-one appointment is where we really understand more about you, your medical history, your diet, your life, what's going on, and create a treatment plan for you. And then in the following 12 weeks that we meet in small groups, it's like mini one-on-one appointments. And what we're going to see is whether our recommendations are working for you or we need new recommendations. And when you're ready to start challenging food. So we'll guide you through step by step the food challenging process so that we can help you identify your trigger and your level of tolerance. Okay, sorry, that was a lot of information at one time. Okay, somebody said, I got a 1-page printout from my GI doctor and he sent me on my way. I'm trying to figure out this little FODMAP on my own, very stressful. We hear you. It is very stressful. And honestly, I have to tell you this. As dietitians, our training is 16 hours, just the training alone. And this is not talking about working with patients. And the training does not give you all of the tools to working with patients. I say the experience, finding an experienced GI dietitian is really, really important. And this is something I keep telling other doctors that we are working together with. Dietitians have to go through 16 hours of training to really understand the low FODMAP diet. Please don't give patients a one-page
It's more
handout.
than that. It's more than
Is it?
that. I think it's
Yeah.
Monash training course is 35 hours.
Wait. Oh
Mm-hmm.
no, I got it wrong. I thought it was
Yeah.
16. Did they expand it? Maybe, because I was
When
the
we,
first batch that was
I
trained.
think it was 25. When I did it, it was
Okay.
25. Now it's 35. But then I was
Yeah.
thinking maybe it was 35 when I did it. It's been a bit of time. But yeah,
Yeah.
it's a lot.
Yeah, and we know that. What the training is one thing, right? It's really having the hands-on
Mm-hmm.
experience is another thing. We have had multiple dietitians come through our program who have been trained by Monash themselves, but they still don't know how to implement it or what symptoms to watch for. This really does come with experience, and so many of our clients have been to multiple dietitians before they find us. I would say there are definitely experienced GI dietitians out there, but they are far and few between. Usually, hospital dietitians are more familiar with diabetes or renal disease, which is kidney disease, and sometimes liver disease. Identifying food triggers and food intolerance is not their jam because insurance does not reimburse this, which is really sad to say. We are actively advocating for a bill to go through that includes, actually, it was included in the expansion of GI nutrition care was included in the bill that they turned down. The expanding the Medicare or Medicaid bill. I think it was either earlier this year or it was last year that was shut down by Congress. So in the future, if I see any of those bills come through, we will let you know. But right now, GI nutrition care is not covered by insurance, which is also why we don't take insurance. And I'm very sorry about that, but we are very upfront with what we charge. Everything is on our website. There's no hidden cost. And I think that's one thing about going to a dietitian is you never know after insurance how much the bill will be, but we are very upfront with our cost. Okay, I think that's it.
Yeah,
So for
I
those
think
of you
so.
joining now, we talked about so many things today. We talked about IBS flare-up relief to help you shorten your flare-up. Number 2 is different types of IBS diarrhea. And number 3 is potential triggers, which is a lot, which is also why, if you're ready to work on your IBS and really get your symptoms under control, this is a good time to work on it. And we are enrolling our last group program in 2025. We only have 4 spots left. So we would love to work with you and help you get better. Let's take control from your IBS once and for all. All right. Thank you, everybody.
Bye.
Bye.